Hi everyone, I am Dr. Avinash from JSS Dental College and Hospital of JSS Academy of Higher Education and Research, Mysore, India. I am reader in the Department of Periodontology. I sincerely thank the organizers for giving me an opportunity to speak in this virtual conference. Today, I will be talking about the role of soft tissue augmentation around the implants. We all know that success of dental implants largely depends on the osseointegration. However, as reported by many researchers, peri-implantitis poses threat to this perception that osseointegration is not the only factor that is responsible for implant success or failure, okay, but maintaining a competent seal of gingival cuff surrounding dental implants or abutments has an important role to play in longevity of dental implants or the restorations around the implants. Now let us briefly compare the key features of periradicular and peri-implant soft tissues. Similar to the tooth, both has junctional epithelium followed by connective tissue. Okay. However, there are some differences over here. The number of cells which are present on the implant site would be lesser compared to the number of cells which are present on the uh, periradicular area, as well as the collagen fibers will be more in number on the implant side. However, these fibers are arranged in vertical direction on the implant side, whereas on the tooth surface or the tooth side, it would be more of horizontal fibers which would attach to the cementum, and thereby it gives more support to the soft tissues. Okay, during the healing phase, the soft tissue reorganizes itself according to the new environment. Histological observation made by Berglund et al. He says that it is easy to appreciate why peri-implant gingival tissue appears to shrink during early stages of wound healing. The longitudinal arrangement of the major collagen fiber groups amplifies the process of collagen fibril contraction in the vertical direction. Clinically, this process is observed as marginal shrinkage. In the anterior aesthetic zone, the amount of gingival shrinkage can be crucial to success or failure of the dental implant. Okay. Further moving ahead, the role of keratinized zone or keratinized gingival zone. In initial days, there were controversy regarding the role of keratinized gingiva around implant tissue. The clinicians and researchers are now convinced about the evidence available, which says that greater than 2 mm of keratinized gingiva can help in promoting gingival health. Based on our understanding of constancy of gingival tissue thickness overlying alveolar bone surrounding teeth or dental implants, and our knowledge of healing behavior of peri-implant soft tissue around the surgical wound, it is possible to estimate the final position of healed tissue around restorations placed on dental implants. The ability of clinician to accurately forecast the final position of healed tissue will underpin the long-term success of any implant restoration. As seen in this picture, this has been perfectly executed. That's why we don't see any peri-implant conditions. On the other hand, unrealistic expectation of reconstituting lost tissue by placing gingival tissue at a greater distance from underlying alveolar bone, such as in the case when implant is apically placed relative to the adjacent teeth, will inevitably lead to future complications. This scenario can arise when the implanted site has been compromised by previous extractions or exposed to long-standing infections. In these situations, bone augmentation should be considered as the part of treatment plan if a stable soft tissue result has to be achieved. The relationship between bone and soft tissue ultimately defines the final aesthetic result. The three-dimensional relationship between implant and surrounding bone determines the soft tissue contours and interdental papilla. In this picture, we can see there is discrepancy of labial bone. That's why the soft tissue is also deficient in this region. Had it been properly planned, the bone augmentation during the surgery could have been done for better results. If the soft tissues are not handled properly, or if correct assessment of the soft tissues are not done, it can lead to peri-implantitis or peri-implant mucositis. In order to prevent these complications, the soft tissue has to be handled carefully. What are the important considerations which we need to take care while planning implants? During the treatment planning stage of implants, special attention to be given to assess the proposed implant site as well as other systemic factors that may influence the performance and survival of the implant. Implant site assessment should include checking for pre-existing pathology such as chronic and persistent granulomatous lesions associated with extracted tooth, non-healing such as non-healing abscesses, dentigerous cysts, etc. Evaluating the anatomical defect at site such as extreme ridge resorption following extraction, determining the biotype of patient, especially when the treatment site is in the aesthetic zone, deciding on the appropriate time for the implant placement in relation to the time of extraction. The systemic factors that require special attention are the important risk factors associated with implant complications and failures, such as past history of periodontal disease and smoking habit. Many of the soft tissue complications can be prevented if it is assessed at initial stages, and if there is some deficiency of soft tissue, it can be augmented at the time of placement of implants. These are the few techniques which can be employed during placement of implants. That is soft tissue techniques, mainly including subepithelial connective tissue graft and rotated flaps. It can be either buccal or palatal. Studies have shown that sites augmented with subepithelial connective tissue grafts at the time of implant placement have shown better aesthetics and thicker peri-implant tissues. When subepithelial connective tissue graft is used with immediate implant placement and provisionalization in the aesthetic zone, it significantly improves maintenance of facial gingival level. Further moving ahead, rotated flap, the buccal or palatal, can be used to achieve primary closure of the implant surface with the soft tissue. Depending on the availability of the soft tissue, it can be either rotated from buccal flap or from the palatal flap. Further, if you notice any deficiencies of soft tissue at the second stage, before the second stage of implant surgery or during prosthetic phase of implants, we can still correct the condition by performing various soft tissue augmentation techniques. The objective here would be to increase the bulk of keratinized tissue and or connective tissue around the implants, and to preserve the height of interdental papilla or inter-implant papilla, or reconstruct inter-implant papillae. We can perform the following procedures to increase the bulk of connective tissue and or keratinized tissue. Free gingival graft, which can also be considered as onlay grafting. Subepithelial connective tissue graft, which can be considered as inlay grafting, alloderm, and modified roll technique. Free gingival grafting, similar to the grafting done for root coverage procedures, free soft tissue autograft can be taken from palate and be augmented on soft tissue deficient areas around the implant. Some of the disadvantages of free gingival graft is the color mismatch, open the donor operation site or the donor site, and also graft shrinkage. However, it is still the procedure of choice when there is inadequate keratinized gingiva around the implant. Subepithelial connective tissue grafting. If there is adequate amount of keratinized tissue around the implants, but there is lack of the bulk of the soft tissue around the implant, it can be either vertical or horizontal. Then subepithelial connective tissue graft is the procedure of choice. This connective tissue can be partially covered or completely covered. It can be performed along with coronally advanced flap or tunnel and pouch technique, or even with the laterally displaced flap. In this picture, we see there is deficient bulk of the soft tissue around the central incisor, the right central incisor, and subepithelial connective tissue graft is being harvested from the palatal aspect. As you can see here, a partial thickness flap is raised and a pouch is being created, and the connective tissue is placed inside the pouch and sutured. Post-operatively, we can see that there has been sufficient thickness of the soft tissue which has been achieved after 8 weeks of surgery. This soft tissue is not only important for good aesthetics, but also it would help in maintaining health of the peri-implant region. Lately, alloderm, that is acellular dermal matrix grafts, have shown positive results in soft tissue augmentation around implants. With the use of this material, we can overcome the disadvantages of color mismatch as we see in free gingival grafts. Further, modified roll technique has been performed to increase the thickness of the soft tissue on the buccal aspect of implant region. As seen in this picture, modified roll technique has been used to achieve good thickness of buccal keratinized tissue in the implant region. Instead of giving incision on the mid-crestal region, the incision is slightly given on the palatal aspect, and releasing incisions are given so as to enable rolling of the flap onto the buccal aspect, and it has been sutured, and the final result is there is good thickness of soft tissue on the buccal aspect of the implant. Further, interdental papilla or implant papilla plays a very important role in enhancing the aesthetics of the implant. If interdental papilla is deficient, it can be reconstructed by using the following technique. Interdental papilla plays a major role in enhancing the aesthetic aspect of the implant. If the papilla is deficient, it can be reconstructed by using one of these techniques: Beagle's technique, Aziz technique, and Han and Takai's technique. Beagle's technique entails the palatal pedicle flap that is folded and tied on itself on the facial side in order to increase the height of the inter-implant papilla. Likewise, in Aziz technique, they employed connective tissue graft to be placed on the defective area and then tucked under the buccal and palatal flaps, thus providing the graft with adequate blood supply. Alternatively, Han and Takai described a technique that makes use of pedicle graft with semilunar incision and total coronal displacement of gingival unit. To summarize, aesthetic appearance and functional longevity of teeth and implants often requires conversion of unfavorable soft tissue traits to more favorable ones. Improvement of tissue quality and quantity can be accomplished with many different techniques and materials and largely depends on clinical presentation of the case and familiarity of the clinician with the procedures and materials available. Identification of causal factors, selection of appropriate surgical technique, and evidence-based material selection lead to predictable success when improving soft tissue characteristics around teeth or implants. Thank you for your patient listening. Once again, this is Dr. Avinash from India.